I wanted to welcome you tonight to our Kidney Supportive Care Fireside Chat. We at AHN host a weekly fireside chat where we engage and we welcome many of our colleagues from East Africa and also around the world to join us. Tonight, we are really fortunate to have Dr. Pankaj Singhai, who is a palliative medicine physician and associate professor currently working in India. He is working at Aurobindo Medical College and Institute, as well as university. He's been working for the last 7 years. And I have a personal connection with Dr. Pankaj because about a year ago, I reached out to him to access some kidney supportive care teaching. And my name is Erin. Sorry, I didn't introduce myself. I'm leading the supportive care program at AHN currently. And we're really excited that he's here with us. So the history is that in India, they have recently had a masterclass on kidney supportive care and kind of leading the way for many of us to learn from. So really fortunate to have Dr. Pankaj speaking to us tonight. He was a gold medalist of the Bruce Davies Award in 2015, as well as a grant recipient from the IAHPC, as well as the MSCC and ASCO International Development and Education Awards. So we're really, really fortunate to have you here with us today and really honored to listen to your teaching. So I'll pass it over to you, Dr. Pankaj, and welcome.
Thank you, Ellen, for inviting me and for the very kind introduction. I'm really pleased to be with you all and to learn about how kidney supportive care is being developed all around the world. So in this session, we are going to discuss about how the kidney supportive care model developed in India and what was the outcome of the masterclass we had. So can I share my screen? Yeah. First, we'll just go into why kidney supportive care is needed, and then we will go how we developed a model of embedded palliative care in kidney supportive care, and then how master class program in kidney supportive care helped us in developing these services. So starting with a roadmap which I really liked. I saw it for some serious illnesses paper, and it shows that with the diagnosis of some serious illnesses, the person has to go through a lot of life events. There may be a lot of symptoms, a lot of disabilities, a lot of psychosocial issues, and he needs a lot of support from various groups. So from the diagnosis of disease to the treatment when he receives, or maybe when the disease is progressing, a lot of things happens and he needs care from a lot of professionals. In kidney, I have modified it a little bit for this presentation. So in patients who receives renal transplant, many of them survive and they have a very good quality of life. They might have, or they may not have, but majority of them may have very good life, or they may have a good survival with that. But most of the patients with end-stage kidney disease are not very fortunate to get a renal transplant, and they might be on dialysis or maybe on some kind of supportive care, what we call it as a conservative care, and they live with this disease and the symptoms because of that. During these diseases, they have to go through a lot of symptoms or psychological issues, and we as a professionals, we want to relieve their distress. So this includes psychological and spiritual care, some advanced care planning, and as a palliative care, it may be end of life care. But end of life care in these illnesses, especially in end stage kidney diseases, may be very, very challenging, because as all of you know, like many a times what happens, they have to undergo a lot of aggressive interventions, which may be into the ICUs, or they need hospitalizations, repeated hospitalizations, and they die with very poor quality of life. In some cases with advanced care planning, there may be orders for withdrawal from the dialysis, or orders for limitation of life sustaining therapies, and that may promotes them to have natural death, or maybe withdrawal from these supports. And at this point of time, we provide them a good bereavement care to the care partners and supporting them. So what all things palliative care do at this point of time? Basically, and the care team, the palliative care team, provide a bridge for combining the life prolonging measures, which may be the dialysis or maybe the kidney transplant, along with good quality of life. So the patients can live longer, as well as with that patients live happier. So that is the role of kidney supportive care, and that is the reason why we prefer to choose the word supportive care at most point of time. Also, along with that, we need to deal with uncertain life expectancies, because a lot of things happens in these patients, and that's why we need to have a frequent reassessment of goals of treatment. So for these things, we started our kidney supportive care in India, and we needed a lot of people to provide a good total care to these patients, as we say in palliative care, that it needs uh, a village to provide a palliative care. It's maybe the doctors, nurses, social workers, counselors, rehabilitation experts, and many more, which I may not have included in this. And we need a good coordination between the palliative care and nephrology team, and also with the community supports with the community representatives. So these all things requires training for everyone, for the doctors, nurses, dialysis team, nephrology teams, and that is the reasons we need to work very closely with them. And that's why we started with a master class. That was an initial master class before the actual master class that we will be talking about. So this master class was very interesting, because here we invited uh, 10 very senior nephrologists from all parts of India, and 10 very senior palliative care physicians from all over India. And then we made 5 or 6 teams, and also included our local nephrologists and palliative care people, nurses, dialysis team, and made a group. This masterclass was taken by Dr. Frank Brennan, and we are very thankful for him that he always supports our educational and training activities in India and all over the world. In this, each team consisted of one national nephrology faculty and one national palliative care faculty, and they were clubbed with the local faculty either from palliative care or nephrology, that was in Manipal. And it also included either a nurse or dialysis technician or a counselor, along with a resident or maybe a trainee in nephrology and palliative care. So that made a very good group, mixed group, and so that a person from each domain can be there. They they learned about this concept of kidney supportive care over 2 days. They brainstormed a lot, And then at the end of this masterclass, they were given opportunity to work on one of the topic. So each team decided like which topics they are going to work on among these six. And over a few months, around 6 months, they worked on that topic all together and came out with a very good supplement that was published in Indian Journal of Palliative Care. And they tried to look at the international or global evidences and how it can be adapted to the country which may not have very good resources or doesn't have a good uh, palliative care teams or palliative care integrations into the nephrology. So it was basically a more of a review of evidences along with how we can implement it in India. Uh, with this learning, we then started a palliative care model in Manipal, which is a university hospital in southern part of India. And we already had a very good running nephrology team and also a palliative care team. Both used to run parallelly, and whenever there was need for any palliative care for any kind of patients, we used to provide a care. And that was the parallel model of kidneys, or parallel model of integrations, where both the teams were working together into their own setups. But with this learning, we thought of starting a embedded palliative care, where the nephrology team were very supportive, and they found a space for palliative care team, so that they can come, they can see the patients and work with for those patients. So for this, we started a palliative care OPD that runs twice a week for a half day. And we used to see the patients who are going to need palliative care in that OPD. That OPD or the clinic was situated basically um, within the nephrology units, or especially in the dialysis unit, where all the patients who are coming for hemodialysis are going to come. And we can maintain a good database or follow up for these patients. Along with that, the palliative care team as well as nephrology team used to have a joint rounds into the dialysis unit and nephrology ward. This was a added advantage for us, because as a palliative care team, we were not aware about a lot of concepts of nephrology. Similarly, nephrology team didn't know about the advances of palliative care, where what actually palliative care team does, or how do they do these things. So this was a great learning for us, like some joint rounds where both team goes to see patients together, and they used to provide palliative care together. And these things helped the nephrology teams to get sensitized into what all can be the triggers for palliative care. Uh, so here I will just go into the common triggers which we sensitize nephrologists for. So like any patients who needed multiple unplanned hospital admissions, the numbers were usually like more than 3 in a year. These were mainly the unplanned hospital admissions, so not for like fistula repairs, or not for renal transplantations like that. But if a patients develop serious infections, or some bleeding, or pulmonary edemas. So if there are multiple unplanned hospitals, then that may be a candidate for integrated palliative, integrated supportive care in these patients. Those patients who are not tolerating dialysis well, and dialysis and transplant may not be an option for those patients. Also, those patients who choose, like, they do not want to go for dialysis, that may be because that was their decisions, or they may not have the resources. The dialysis facility is not available nearby them. So those patients who choose not for dialysis, or withdrawal from dialysis, or not opting for dialysis after transplants, these patients were also kept for kidney supportive care. Also, interestingly, the complex physical symptoms where the nephrologists find it difficult to manage, this is also one of the criteria where they can involve kidney supportive care team or palliative care team, and the palliative care team used to help them. The interesting thing was about the prognostications, because in the diseases like kidney diseases or neurological diseases, it may be very, very difficult to predict their survival. But a very important concept of predicting survival may be uh, multiple comorbidities, or those patients who are not doing very well, or surprise questions. These things were helped nephrologists to undergo uh, 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 basic trigger for palliative care referral in these patients. Then how we assess these patients. So we had a preliminary assessment sheet for kidney supportive care, which had basic demographic data, as well as what are their comorbidities, what are their symptom burdens, or what all treatment they have underwent through. Then some psychosocial assessment sheet, which social worker or the counselor used to assess for. Then for symptom burden, we used to use the ESAS Renal. We had translated and validated in our local language, and we were using that ESAS Renal. We found it very, very helpful for those patients who are coming to OPD or for the dialysis room, and they can just take it out, like which symptom is really troubling them. Then for research purpose, we used quality of life scores, that was EQ5D5L. That was again very easy to measure. We used Karnofsky performance scale for those patients who are not to assess how they are working, and also for few patients, like goals of care documents and follow-up charts were used. So this gave us a good documentations about the patients in kidney supportive care OPDs. Then what all we did in these patients. So once the nephrologist finds like this patient is eligible for kidney supportive care, the palliative care team used to do initial assessment about the symptoms, their psychosocial needs, and then along with patient-centered care, shared decision making used to be done. And for that, we had a goals of care discussion with the patients as well as with family members. And at this point of time, the patients or family members can either choose for renal replacement therapy or dialysis, or may choose for conservative uh, uh, care. In both options, they have access to kidney supportive care, either on dialysis or on those patients who are on conservative care. Both patients have access to kidney supportive care team. So in patients who are undergoing dialysis, is maybe uh, for symptom management, and for kidney for conservative patients, it may be for holistic management for these patients. What all things we did in these patients were like management of complex symptoms, including pain management using opioids, infusions, and all. Then management of symptomatic renal failure in those patients who are on conservative care, so like the nausea, vomiting, anorexia, pruritus, or reduced functional status, and those patients who are having intractable fluid overload causing dyspneas and all. Also, very important part of our team was having goals of care conversations, and we wanted to identify and discuss their goals and preferences and their values, and so that we can direct treatment accordingly. Also, uh, we had end of life care provisions and the home-based care provisions for these patients. In our kidney supportive care embedded model, we had done a SWOT analysis, like what all things can work well and what all we had to improvise. So our strength in this model was we had really a good number of patients who need kidney supportive care. So there was already felt need by nephrologists, like there are a lot of patients who do not want dialysis, or those patients who are actually on renal replacement therapy. They have a really poor quality of life or very high symptom burden. So that was one of the felt need by the nephrologist, and that's why they felt like we need someone from palliative care into nephrology also. We used standardized tools for assessment, and actually we translated or we developed our tools so that we can use it for research purpose, and we can make policies for for the nation, other clinics, so that they can work. We had really good support from nephrology team. As you can see that they gave us a space. They invited a palliative care team for joint rounds, and also from administrations for running a separate kidney supportive care. Another very important thing was Blue Maple policy. I don't know if you have heard of it, but this was our institutional end of life care policies, and which very clearly gave us an idea how to approach those patients who have serious illnesses, and how they can go ahead in a very systematic way about the limitation of life-sustaining therapies like uh, dialysis or uh, intubations or ICU's care. So in this Blue Maple policy, we had the first step of recognizing the medical futility, where the treating physician used to identify like these patients may not do very well with very aggressive interventions. So once the medical futility is ascertained, then there is discussion among the treating physicians. So like the ICU physician, nephrology team, and palliative care team, they used to make a consensus whether this medical futility is correct or not. Once this consensus is achieved, we used to discuss this with the family members, and we had a proper checklist and the communication documents for the family meetings. And the advantage here was, like, we used to have a joint family meeting where the nephrologist as well as the palliative care team used to sit together with family, and we used to discuss like these are the reasons why we feel this can be medically futile, and what we want to offer in these patients. Once family members or patient they understand about these issues, we used to implement our end of life care, and the patients used to be referred to palliative care team for end of life care after proper documentation. This I am talking about before we had Supreme Court guidelines. Now, recently, last year, our Supreme Court had come up with guidelines about how to deal with those patients who have very critical illnesses. And now these things are much easier. But before that, it was very, very difficult how to go about in these patients, and these policies really helped the clinicians to go in a very, very systematic way. But there were some weakness also, like we didn't had really trained healthcare personnel who had a good training in kidney supportive care. We all were recently learned about kidney supportive care model from Dr. Brennan. Uh, this concept was also very new for patients and family members. They were not aware about what is palliative care. Most of the patients thought like this is something for cancer patients or only for end of life care. And also at that point of time in 2019 or 20, we didn't had very legal provisions about advanced care planning, and there were very a lot of practical challenges about advanced care plannings or liver bill. Other than that, there were good opportunities for us. Like this was the first time dedicated kidney supportive care clinic was started in India, and that's why we received a good support from both nephrologist and nephrology association, and as well as kidney palliative care association of India. This was a very good option for those patients who do not wanted a dialysis or renal transplant, and to provide them continuity of care that was very much welcoming by both by hospital as well as by the patients. Here, because it was patient-centered care, and we had a good shared decision making with nephrologists, with family members, with the patients, and that's why it was welcomed well. Also, we were fortunate that our project was funded by the ICMR, which is the topmost research body, that is in Indian Council for Medical Research, and we didn't had to fight for the funds for that reason. So that gave us stability to run this project. What are threats which were perceived? Like we thought like physicians might hesitate or fear for palliative care to send those patients. Also, like the patients may have a stigma that we are not doing everything they want. So this was our SWOT analysis for kidney supportive care model. As I said, like this model was started as one of the research models. So ICMR funded us for this model of integrated renal supportive care in the symptom burden, quality of life, and advanced care planning. We have started it, and this model is still undergoing, but we have come up with a few publications with this team, and we have developed a questionnaire to explore the patient's preferences, family caregivers, and kidney supportive care providers in advanced care planning. And also we had recently a survey on advanced care planning in nephrologist in India, and what they found, like they recognized its importance, and they felt like ACP is still being underutilized in our patients, and we need to have a very targeted intervention so that we can overcome these barriers, and so that we can enhance our practices of noting down the living bills as well as advanced care planning. This was the publication which we had as a special supplement in IGPC. If you want to go through, you can just go through this link. Also, this led us to have some elective postings for nephrology residents. So all the trainees or residents who are undergoing nephrology training, they had a few weeks of postings into palliative care or kidney supportive care clinics, so that they can learn about these concepts. Also, for all dialysis technology undergraduates, they also had an option of undergoing elective modules in kidney supportive care, and that can give them some idea about these patients may benefit with kidney supportive care. Our team also published a chapter in postgraduate training for medicine about conservative kidney options. So that was about the our model of kidney supportive care. Now I will just take you through what all educations we had gone through. So this is we started in 2018 with some eco models, like that was on Zoom. Around 50 participants uh, had joined for this program, and in this lecture series, Dr. Frank Brennan started with various topics, and this was I think the first time we learned about palliative, or we heard about concept of kidney supportive care from Dr. Frank Brennan. This is still available on YouTube if you want to go through. This is a beautiful series which he had taken, and along with that we had some local very senior nephrologist who gave insight like how these things are needed or can be developed. Then, as I said, in 2019 we had in-person masterclass by Dr. Frank Brennan. In 2023, last year, we had a major track in our national conference where around 100 people they discussed and they presented their evidence about kidney supportive care, and a good participation was noted. Then we started our another master class that was Impact Nephrocare, which ran for around 9 to 10 months. And this we designed along with the help of various international faculties, where we covered a lot of topics like what is the need for kidney supportive care, what all are the global movements going about conservative kidney models. So you can see there are a lot of topics which were there. How we started this master class was we started with those trainees who are undergoing palliative care training, as well as those who are into the early career in palliative care. So this because this was the first master class which was open for everyone. So we started with young palliative care people, as well as with the nephrology trainees as well. Here all videos about the recorded lectures was put by various global faculties, as well as there were very focused informations about the literature, what all evidence do we have, and some practicing modules. So there were many MCQs, or people has to write some reflections on what all things we learned. And then there was a live interaction at the end of every month. So every third Saturday we used to have a discussion about what all things they have learned on their learning management system. And at the end of it, some of the resident or trainee or the participants used to present cases which they had seen, or they have found some difficulties that was matching with the topic what they learned. So at each live sessions we had some expert faculties. Many times these faculties were the same who had recorded the lectures and which the participant had seen. So that was one of the opportunity for all the participants to have a live discussion with the faculties. This was in brief about the masterclass Impact Nephrocare. Impact Nephrocare was like immersive palliative care training in nephrology, and we found it quite helpful through the feedbacks of participants. And it is going to be launched. The second session of masterclass will be launched very soon, maybe in earlier months of next year. That was about Impact Masterclass from my side. Thank you. Thank you so much.
Thank you so much, Dr. Pankaj. Lots of interesting questions coming into the chat, and I was trying to take screenshots and links and all that, but I'm sure you will be sharing the slides with us after, so we'll definitely get them
Surely.
to participants. But I'd like to facilitate a time of discussion with the group. And there's been some really interesting questions in the chat, so I'd like to wonder if we could do that poll that we had talked about doing at the beginning, but we could do it now.
Oh, I really forgot about that.
No, it's okay. I also forgot. But we, as a speaker and facilitator, are really interested to hear who's in the audience today. So we're going to put up a poll now. I think Dr. Yuri can start it. And we're just curious to see who's in the group. Okay, so the question is, what do you do? Which of the following best describes your professional background? So you as a listener, are you a trained nurse in kidney supportive care or palliative care? Are you a palliative care doctor? Are you a nurse trained in nephrology? A clinical officer? We know in East Africa, we have the cadre of clinical officer trained in nephrology, a nephrologist, or an other, including social workers, technicians, or psychologist. So if you want to vote now, then we'll see as the... All right, great. So we've got the majority of us on the call today seem to be nephrologists, including pretty close as well nurses trained in nephrology. So we're still quite few nurses and palliative care doctors on our session. And that was kind of what I had anticipated, that most of us that were on the call would have been providers in kidney care, and still growing in our region related to that overlap between palliative and kidney patients. But great, thank you for participating. That really does help us as we think more about our audience and who's joining us on these calls.
Thank you. Thank you. It's interesting.
All right,
Yeah.
Dr. Pankaj, so some of the interesting questions that have come through. In the work that you've done in India, obviously it sounds like the team is really building off of very strong training and getting into really robust research. This question is related to the communication protocol across teams. So how does your team work in an interdisciplinary way so that we ensure that when patients have an update or something changes, especially when our patients have complex needs, that not only the nurse knows about the change, but the physician, maybe even the palliative care team, if it's a team that they go to visit. How does that work?
Thank you. It's really a very important thing in patient care about the communication among the team members, because many times what happens, like nephrologists are talking about something else and palliative care team is talking about something else, and the patients or family members are really confused. So that's why means if you remember, I spoke about our blue maple policy. So where the first step was the clinician was identifying about the complex situation of the patient, and then they used to have a discussion among themselves and they used to come to a consensus. So that was the first step, like the nephrologist is identifying a patient who might need palliative care integration, and he is speaking to someone from palliative care, and then they together used to discuss it with the family members, so that there should be a very clear message should go to the family members. That was the first step, but things doesn't stop there. After that, in the care team also, we need to like the message should be very clear. So that's why the documentations about like what this patient is going to need, that is also very, very important. So we had a communication checklist where the doctor or nurses used to tick like which pathway this patient is in. Is the patient is going for aggressive interventions, or wants a conservative care, or this patient needs end of life care policies. So I feel that checklist or documentation is very, very important at this point of time, and also communication among both people. And the thing that helped both team, the palliative care team and nephrology team, uh, was like learning these things together. The palliative care team also learned from nephrology team, and nephrology team also learned from palliative care. So that interdisciplinary learning from both the team helped really helped us. So I think that may be something we can work on, and that actually helped us.
Yeah, for sure. We currently at AHN, we have a weekly team meeting with our supportive care team where we have our nurses and our clinical officers, as well as our kidney supportive care nurses meet. And I think, although at times it feels like we have lots and lots of meetings, these are kind of the backbone as to how we communicate and really build that team dynamic, which is so important. Lots of really good questions. I hope we'll get through them all. So another really interesting one, are there specific assessment tools? I think you talked about it quite a bit, or quality of life metrics that would allow your team to track the impact of the supportive care intervention that's patient-centered. So I think you had a list of 5 different ideas. Can you speak a little bit to some of those very specific palliative scales? I know now, based on our audience, that we have more nephrologists and nephrology nurses. Can you explain maybe 1 or 2 of those that you think are the most important?
Yeah, I think for quality of life or some assessment tools which are important for these patients, the most important I found is the symptom assessment tool. That may be either Edmonton, that is ESAS Renal, or maybe IPOS. IPOS is another very beautiful and very simple tool that we can use it, and it has been validated in or even adapted for renal diseases. So IPOS renal or ESAS renal, very easy. Like you can give a printout or applications to the patients or attender. They can feel like this symptom is troubling them from 0 to 10, or very less to very often. And this can give us an idea like this is the patients who need to be looked at their physical issues or psychological issues or communication issues. So ESAS or IPOS, this is I think the first tool which I would recommend it for everyone. It may be for the nephrology nurse, the dialysis team, dialysis technicians, or the nephrologist. And this also gives us an idea about how much difference your treatment or your care plan is making to the patient's life, because you see that this patient's score was 8 and now it has come out to 2 or 3, and that gives us an idea like this patient has some impact of kidney supportive care interventions. Similarly, there are some quality of life tools. We found EQ5D5L very helpful because it is very easy to do. But otherwise, like there are other quality of life tool like something like KSQL, a short form. I may be missing the correct name, but those are also very commonly used in kidney supportive care. So
yeah, that's great. What we find here in East Africa is, I think these tools are really helpful. It does definitely require buy-in from our staff because they do sometimes take a bit of time. And there's an interesting question that has come up related to sometimes our patients ability to engage on concepts of supportive care with our patients, where understanding people's health situation may be difficult. So patients' health literacy can sometimes be a challenge. How do we then not only explain the concept that they have a serious illness, that they may require some extra support, like supportive care, and then ask them a bunch of questions about their symptoms using a scale? How do we support patients to even want to answer some of these types of questions when maybe their literacy or their understanding of their illness is low?
So it is a common challenge in our part also, because not all patients knows about what is going to be the prognosis of this disease, or what all are the treatment options, or is there really an option of supportive care, or what does the conservative option means. So it is important. It was important for us to know how much do they actually understand, and that's why we had conducted a survey among the dialysis patients, like what is actually important from them. It should not be very much like the Western concept for them, like the concept of advanced care planning or living wills. Is it really important? So that's why we conducted a survey with the patients, with their family members, and the nephrology providers also, so that the real issues can come up. The second thing was about like how we can actually make them aware about these options, because the literacy may be an challenge in these patients. So we had some support group meetings, especially when they are coming for dialysis, those patients who are into the clinics and all. So because they know each other, and if one patient is connected with kidney supportive care team, many times he used to tell other patients, like, this is one of the concept, and I am really this concept has helped me. So that was one way how the patients or family members can actually educate the other people, and that was the advantage of having them together.
There's some interesting questions as we come to an end. I don't know if you want the easy question or the hard question. They're both hard.
Anything is okay. Yeah.
No, I'm just kidding. Okay, so you mentioned that one of the threats to some of the studies was a hesitation from nephrologists to start the supportive care process. We would love your thoughts on this. We at AHN work with consultants a lot. We have over 20 clinics in Kenya, and we're growing outside, including Rwanda, Tanzania, Zambia. How do we engage with our colleagues who are actually on this call right now to ensure that we do encourage and grow these programs for our patients?
Yeah. Thank you for asking that. It's really like this was one of the perceived threat, like the nephrology community can perceive palliative care as one of like end of life care, or mm, or supporting the families at when the patient is actually terminal, or gasping for breath, or just dying. But the kidney supportive care brings a larger umbrella, a bigger picture, and that's why we wanted to educate them, like this can be offered to those patients who might be on treatment, who are on dialysis, or those patients who doesn't want it, but they may live for many months or few years. And our basic concept is to bring back their quality of life. We want them to have their choices or values should be respected at even when they have these diseases. So basic education about palliative care, that it doesn't mean only end of life care, although end of life care is a big big concept, but also providing them a good quality of life, helping them to live better, and also in supporting family members also in these situations. These all things comes under palliative care or kidney supportive care, and that was one of the reason uh, why this term, the kidney supportive care, is being more utilized rather than just kidney palliative care or renal palliative care.
Yeah. Sorry, my video just cut off, but I'm still
No
here.
problem. Yeah.
We have a question about how do we provide support, especially related to our kidney patients, when maybe an individual's religious beliefs could be a barrier. So how do you, we know in India, obviously there's many people, there's many different beliefs and religions. How do you address spirituality with a kidney supportive care approach?
Yeah. So I would say like this concept varies a lot in means leave the kidney diseases, but it's in the all diseases, because in India we have very varying religious pictures or spiritual issues. A lot of them
Yeah.
connect spirituality with the religious things, but there may be many people who have their other concerns also. So this is one of the very neglected part in healthcare. But when we talk in palliative care, the existential issues or spiritual issues are very important for us. Uh, Main thing what we do is mainly identifying what is troubling them, and what actually do they want in their care. So and the FICA score, if you know about the FICA tool. So like the faith, what faith do they have, what is important for them, and what do they want in their care, and actually what do they want us to be addressed. So these things actually helps us in uh, providing a spiritual care. Most of the time identifying what actually is troubling them uh, uh, finds them answers also. So once they know like this is the thing and that is troubling them, they themselves find then answers to that question or to that distress. We just need to facilitate the things. We just need to have a very open communications with these patients. Most of the time, religion is not a barrier for them. It is more helpful, because they themselves come up with the answer in their religion practice also. So sometimes, like in Hindus, this thing they say like the death is ultimate truth, and uh, uh, like they quote those things like this is going to come, and basically what we want is to have a comfortable ending.
Yeah. I know in parts of Kenya where we're working, we have found it really helpful to engage with religious leaders because they're such a trusted member of the community. And it does takes a little bit of sensitization and talking to people about what it means to have a chronic illness to make sure that the person that the family and the patient trust the most is also saying something similar to what the healthcare team is saying. So I know that that's been an effective thing for us as well. It seems
Okay.
like Dr. Amar has really, really important questions. Dr. Amar, you're not making this easy for us. So we'll take one more question.
Surely.
And do you know Dr. Amar or Dr. Swali?
I'm sorry, I'm not familiar with Dr. Amar.
Okay.
Yeah.
He's working, yeah, he's working in Tanzania. And
Okay.
obviously
Wow.
I think he's transitioned to, I think we should get him into a palliative care fellowship. Hint, hint,
Really, I would
hint.
love.
Dr. Swali. um, So I can send a few of these questions on to Dr. Pankaj, and we'll definitely bring them back to the group. But there was an interesting question from Jacqueline, who's messaged me and said that, do you in India include children in your practice? And I think maybe just if you're able to answer that in 5 minutes, we'll close with that question. Do
Yeah.
you support
Yeah.
children with kidney failure?
Yeah, so the shortest answer is yes. Like the patients who have kidney diseases, the children who have kidney diseases also are included in our kidney supportive care. But to be very honest, I find it very, very difficult because their challenges are really difficult. And they need very, very intense palliative care support. We need to support the family members also. For parents it is very, very difficult to accept it. uh, it is difficult for them to seeing their child suffering, and many times if there are no support for kidney transplant, or he is not suitable for renal replacement therapies at this point of time, we as a palliative care team has to support them.
Yeah.
So yeah, pediatric in pediatric populations also we do provide kidney supportive care, although the number of these cases are somehow less, but the challenges or the resources needed in these populations are really, really high.
Yeah, we have an interesting case in Kenya where our kind of initial implementation has been for kidney supportive care. There's only 2 hospitals that offer pediatric dialysis. So what tends to happen is either children are not able to access it, which is, like you're saying, extremely difficult. And if they are able to access it, they either have to move or they travel many, many hours multiple times a week just to get treatment. So I do agree, it's a very complex situation, especially when we think of finding ways to holistically support children and their families. And I think probably a conversation for another fireside chat, maybe. Because although they are few, I agree with you. We do need to have some good, solid solutions and ways to encourage our staff to support these families as well.
One of the other challenges, not everyone is equipped or they have trained to take care of children, even for
Yeah,
palliative care provisions. So that also
right.
makes care provisions a bit challenging.
Yeah, definitely.
Mm.
Well, I have received the final question for today. Thank you for everyone who's joined. If you do need to leave, no problem. But Dr. Pankaj, do you have 2 minutes? Last
Okay.
question is
Yeah.
related to respecting autonomy of our patients. So we know that we in East Africa, in India, of course, as you were saying earlier, um, we acknowledge the different values and the core principles of palliative care, yet we also work in cultures where decision making can be very different than maybe where palliative care originally came from the UK or more of a Western kind of philosophy. So how do you within your program really help engage family members in that decision making, especially when these decisions sometimes are very complex related to treatment choices and yeah, what are your thoughts on that?
Yeah. So this thing is really challenging in especially in our parts where the family members usually make this decision. Um,
Mhm.
Most of the time family members says no, don't tell anything to the patients and tell the things to us, and we will discuss in our own way to the family member, to the patients. So that's why like we have a layer before between the patients and the doctors, and many times it's a collusion. The family doesn't disclose the prognosis or even the diagnosis to the patient, and that's why the autonomy many times it is compromised. But what we insist on, we usually do not break that trust or that bonding between the patients, family members, and the doctors. So directly, we do not speak to the patients without family members' consent. Uh, but we insist on telling, like, why is it important, why talking to patient, or why understanding what he or she actually wants is important. And we also share with them how it helps for you in situations when he will not be able to take decisions, or he will not be able to be in the positions that he can talk or not. And it at that point of time, the treatment options will be very, very challenging. So we usually counsel family members that it is important that we have a direct communication with patients, or very honest communications, so that we can respect their autonomy. But saying is very easy, and doing it is quite difficult. But many times, yeah, family understand, and they have these discussions. Sometimes they says, like, we ourselves would talk to the patient first, or many times they say, yeah, let some expert talk to them about these situations. So they allows patient directly to talk to us, and we involves counselors, sometimes volunteers, to have these discussions. And then slowly they come, once the patients or families comes into terms, and then the doctors or nurses also started to talk about these issues, about the treatment or advanced care planning.
Yeah. So it sounds like still trying to keep our eyes on the importance of some of these principles and just being patient, kind of slowly supporting families, continuing to focus on the caregivers to ensure that, we're in line with their values as well. But yes, sounds like it is complex. It sounds like we're also dealing with similar issues here in our region that you are.
That's there. Yeah.
Thank you so much. I'm gonna pass it to Dr. Lloyd. Dr. Lloyd, do you have any final thoughts as we close the session for tonight?
Thank you so much, Dr. Pankaj. It's a wonderful session, and I really think it's a brilliant idea about the masterclass. And we hope that we can, take part in the masterclass that comes up next year. We really think that that's a lot of work that's gone in, and also Dr. Frank Brennan, I think, has been doing a lot of work. I have met with him. He was also interested into working into Africa when I last met him in 2022. Yeah. And then I think that's a great idea that I think we can also make use of his resources. Only thing, the timing will change. And the last thing is, what is the connection with Manipal? Well, that's something I didn't understand. I thought you were in Aurobindo.
Yeah, I was working in Manipal before this, and recently I have to move from Manipal to Aurobindo. So that
I know
was my
Dr. Prabhu.
connection. Yeah.
I know Dr.
Wow.
Prabhu and Darshan very well. Yeah,
Oh,
I guess
wow.
they would have been there. Yeah,
Yeah, they were very much part of team,
the
and
whole. Yeah.
very, very
Yeah.
supportive people.
Yeah, Rabindra was with me in Vellore, was junior to me in Vellore, and
Okay.
Darshan was later. Yeah.
Okay. Yeah, that's great to know.
Lovely, great connection.
Yeah.
Thank
So thank
you
you.
so
I
much.
really like this fire chat and the interaction we had, and we will stay connected, definitely.
Yeah, surely. We need you more often. Whenever you have the time, we won't trouble you. But I think this is a great discussion and a lot of insights and a lot of literature that we can actually go through, and a lot of ideas that we got from the masterclass.
Yeah,
So we
sure,
really hope
sure.
that we will have a great program in the coming, year or two to really develop the program. Thank you so much.
Definitely. I would also love to learn from all of you. Thank you.
Well, thank you everyone for joining us. Thank